Believe it or not, exam 1 is on Monday, right? I know it comes a little fast, but I used to just have 3 exams in this course, and the students did not like that there was so much information on each exam. So I've gone to 4 this time. So they come early. I mean, what can I say? Then the next one is about 5 weeks after. So please start. Hopefully you've already started studying. This is not the kind of class where you can study the day before and hope to have a prayer of doing very well on the exams, right? Because as you all have probably figured out, A&P2 is very conceptual. You know, it's not like there's a list of terms or a list of definitions to learn. You know, you've got to go through the physiology so that you understand how it works. You know, A&P2 is very much about how things work. You know, like we saw in the endocrine system, you know, that you've got these multi-step processes that have the hypothalamus controlling some target endocrine organ. You've got to go through the steps. We will have time to review. We may even get to some review tomorrow, but for sure we will have time to review on Thursday. Please bring questions, okay? If you have something you really want me to go over again, let me know on Thursday, because the first thing I'm going to say on review days is, what would you like me to talk about? Okay, and if you don't have anything, well, then I'll just start talking about stuff that I think is important, right? So do bring questions. That's a piece of how that review system works. We will have our exam in the computer lab just like we did last semester. We're in Walsh 236. That's the big lab in the corner, I'm pretty sure. And we'll have plenty of room because that lab seats like 35 students, and there aren't nearly that many of you. The homework for this chapter will be due on Thursday. Thursday is our review day, so we'll be done with this chapter by then. So I have the homework due, obviously, before the exam, because the homework's a good study tool for you. So hopefully you open that up and have started looking at that too. Okay? So begin, exam on Monday. Okay, so that's point number 1. Point number 2 is on the screen right here. And you'll see that the third, I guess, of this PowerPoint set is a bunch of pictures of vessels, okay? And like I said to you last time, I don't think this kind of anatomy is learned very well in class. You know, I can bore you to tears and go over each of the names of each of the things, but that's not going to stick in your head anyway. Okay, so what I've done is create a kind of visual study guide for you. So this is the table of contents of that visual study guide. Okay, these are the vessels. All the vessels on this slide are vessels that you're responsible for knowing. Now, many of these you should already know because we did arms and legs and head and neck last semester, right? So those vessels may appear on this exam too. The only new ones for you should be the ones in the trunk. And for the most part, except in the arms and legs, arteries and veins go together. So if you learn the artery names, you've learned the vein names already, because arteries and veins travel together in the body. The exceptions to that are in the arms, or arms and legs, where there's a deep artery and a deep vein, and then there's a superficial vein too. So there's some unpaired veins in the arms and legs, like you probably talked about last semester. I know we did when we talked about the legs a little bit. So this is the table of contents, so these are the things you're responsible for. Now, the rest of these pictures are much better pictures for learning these vessels, right? Because it zooms in and looks at it region by region, which shows you a little more detail. But in some of these pictures, there are named vessels that are not on the table of contents one, right? This is what you're responsible for. These are just better study guides or better study pictures. And all of these are right out of your book. So you should have, here, let's make it big to show you what I mean. So you should have a pretty easy time, figuring these out. Because you've already studied the arms and legs and head and neck, I might start with the central vessels instead. So these pictures, right? Descending aorta, superior and inferior vena cava, and so on. All right? Okay. So that's, if we get to some of that, if we have time, I may go through some of the key things like the circle of Willis, but we'll see as we get there. Okay, yes.
Will you ask us the questions on annual?
Yes, they will open up on Thursday. I'll open up the endocrine ones after class.
Okay.
Let me make a note of that so I'll remember to do that. Open. And if I forget, this is a thing I forget often, so just remind me. And if you're ready to study and they're not open, just email me. I usually get email pretty quickly and respond quickly. Okay. All right, so on to the business at hand. Okay, so we talked last time about, what is circulating in the blood. We talked about red cells a bit more, hemoglobin. We talked about the 5 different kinds of white blood cells. I gave you a couple of things to remember about each one, the claim to fame that's in that table. So as we move on to looking at, what does the blood do? Well, one of the things it does that makes it very different than, any non-living fluid is this trick of what we call hemostasis. Hemostasis is keeping blood in the blood vessels and not anywhere else. So the fact that we don't see our own blood very often, anyway, is an example of hemostasis at work. Blood stays in the blood vessels because that's where blood belongs. That's where it does any good. If you have blood flowing out onto the floor, like in some major trauma, that blood is not circulating oxygen around the body. It's not carrying nutrients and it's not carrying waste products because it's going onto the floor. So in order to have a functioning cardiovascular system, we need the blood to stay in the blood vessels. And we call that hemo is blood, stasis is maintenance, right? So hemostasis. Not to be confused with its sound-alike, homeostasis. Homeostasis is the organism maintaining its own balance. Technically, hemostasis is part of homeostasis, but they're not the same thing. Okay, so be sure you're reading the right word, not homeostasis, but hemostasis. And in our everyday language, we call this the clotting system, which isn't exactly a precise term because there's more to it than clotting, but that's what we call it. All right, so we divide, like we will in so many complicated processes in the body. We'll divide things up into different phases so that there isn't so much to look at once. All right, so the classic injury here is something has cut the wall of the blood vessel. All right, it might be a knife, it might be a thorn, it might even be a deep scrape where the vessel wall has been eroded away by some trauma. Well, the first thing that occurs has to do with the vessel itself responding to that injury. Remember, our pipes are alive. Unlike the pipes in the wall, our pipes are alive. They're made of cells that can change and do things, and they do. So in the vascular phase, the vessel itself responds to the injury. Okay, so one of the first things that happen, as you can see in the picture, is vasoconstriction. Vasoconstriction is when a vessel gets smaller. Vasodilation is when a vessel gets larger. And because the walls of our arteries in particular, but veins too, have smooth muscle in them, they can change shape. And they do so all the time, regularly. All right. So in this case, if we have a severed vessel, one of the smartest things to do is to make that pipe as small as possible. Because physics says the smaller the pipe, the higher the resistance to flow. Right? So this, you experience this. You've got a big fat drinking straw you're going to drink a milkshake with. Or you've got those little tiny coffee stirrer straws, right? Much harder to pull fluid through the tinier opening. So the body takes advantage of that physics and clamps down. It makes itself as small as possible. That reduces the amount of blood that's lost through this gap because there's higher resistance, so less blood flow. In small vessels, this spasm is so intense that the two ends of the vessel actually seal themselves off. In other words, they clamp down so tightly that there is no lumen anymore. There's no hole. The lumen of a thing is the open part on the inside. So this is the lumen. This is the lumen. We're going to use that word a lot in this semester. So in a pipe, the water is in the lumen of that pipe. Okay, it's in the open part of the center. All right, so we get vascular spasm. That's one of the first things that happens. Helps to dramatically reduce bleeding. Doesn't work very well in large arteries, though. Your aorta, for example, is so large that it can't contract enough to keep you from bleeding to death. With a severed aorta, is very rapidly fatal. Okay. So that's one event that you can see. Another event that occurs that you can't see is changes to the endothelial cell lining. All right, you might ask, well, what the heck's an endothelial cell? If we look at a vessel in cross-section, it has a wall, and we're going to talk much more about this later, but lining the pipe is a layer of wrinkly cells called endothelial cells. And we call them together the endothelium, right? And one way to think of these is it's like a living nonstick coating on the inside of our vessels. You know, blood is inherently sticky. You know, it likes to stick to stuff. So in order to flow real smoothly, we need to have some anti-stick properties. And this lining of cells on the inside of the pipes do that. In the normal case, they're very smooth and they're very slippery, so blood just whishes past them. But when a vessel is injured, those endothelial cells change. They actually pull apart from each other so that the underlying tissue of the vessel is exposed. So here, let me see if I can draw that. All right, so I'm going to zoom this in. Okay, so we'll take a piece like that. And normally, the cells all touch each other, right, like that. Because what good is a nonstick coating if it has cracks in it, right? You know, like an old Teflon pan, it stops working well because the metal is exposed. Well, when there's an injury, like here, these endothelial cells all contract and they pull away from each other. So that instead of all touching, you've got these spaces now between them, and the underlying tissue is exposed, right? And it turns out that that underlying tissue is hugely reactive to the platelets and to the clotting system. So normally when all the cells touch each other, like over here, there isn't any reaction to this underlying tissue because it's blocked. You know, the cells, or the blood cells and the plasma can't get to it. But when these endothelial cells contract, they expose the underlying tissue and they set off some of these next two phases, which result in a blood clot in that region. Bless you. All right. The other thing the endothelial cells do is they release chemicals that promote clotting when there's a damaged area. So even if, let's say, here's the damage, these cells will release chemical mediators, chemical messengers, but so will all the other cells in that spot. It's kind of a team effort. They all essentially start calling out, hey, we need a blood clot, hey, we need a blood clot. They just do it with chemicals instead of sound, right? So you get the release of chemical mediators. Those are called endothelins. See that word right there? So those are chemicals from endothelial cells that promote clotting. Now, in modern research, you know, cardiovascular disease is one of the number one killers of people, right? And unfortunately, in a lot of cardiovascular disease, there isn't a lot we can do to help somebody who has advanced, you know, let's say atherosclerosis. All that to say, there's a lot of research being done on what these endothelial cells are up to all the time, because it turns out that they play a major role in cardiovascular disease. So while 10 years ago, endothelins as a word would be something you'd learn in an advanced physiology class, today it's become much more important because we use some medicines to affect these endothelins and help to reduce cardiovascular disease problems. So many of your grandparents, for example, you know, they might take a baby aspirin every day, right? Well, it's because aspirin affects these endothelins. Now, that isn't why aspirin was invented. It was invented for other reasons, but it has that effect. So if you take a little aspirin every day, the endothelins are a little less vigorous, and it means you're a little less likely to clot, particularly a clot somewhere you don't want to clot, like in the heart, for example. So endothelins are the chemicals released by these endothelial cells in response to damage. All right, so that's number 2. They release chemicals. And number 3 is the endothelial cells themselves become sticky when there's an injury. You know, so, you know, here's our knife blade, right? It's cut into that vessel. So not only do they contract and expose the underlying tissue and release chemical messengers, they also get sticky. Now, why is that a good idea? Well, rushing through this pipe, right, are blood cells and platelets, which I'll make little dots. If we've got a hole and we stick a bunch of stuff to it, well, that's going to seal the hole, at least temporarily, right? So this endothelial cell stickiness is part of what ends up making a plug that closes this hole temporarily until a clot can form. Okay, so all four of those things happen in the vascular phase. So the vessel gets smaller, the endothelial cells pull away from each other, they release their chemical messengers, those endothelins, and then they get sticky. All right, and you'll see how those play a role as we continue out. So this all happens in about the first 30 minutes. Okay, the vascular spasm happens in seconds, even milliseconds. It's very, very fast response to stop that bleeding. Then what comes next is what we call the platelet phase, because the platelets are going to play the major role in it. All right. So what are we looking at here? Okay, so this picture is similar to this that I drew. So here's the vessel wall, right? Here's the endothelial cells, okay? And here's where that knife cut through. So we've got damage here. And in purple, we have platelets. Platelets will stick to anything except endothelial cells, okay? And they don't stick to red cells or white cells or inactivated circulating platelets either. Okay, so normally they're not sticky. But when a platelet encounters not an endothelial cell, it sticks. And when platelets stick to something, they then become sticky. You know, this is where these are living things, not Legos. You know, Legos you can put together and they don't affect each other. You have to do it. Well, living systems can make changes to how they behave. So a platelet out here, not sticky. But when it lands, when it gets stuck to something, to the damaged area, it becomes sticky, and the next platelet that whips by gets stuck to it, which then that platelet becomes sticky, and before long, you have this clump of platelets clogging up the hole. Pretty good idea, right? Okay, we've sealed the hole. No more blood is coming out. So why not stop there? Because platelets are not very strong. They're little packets of cell membrane. So the platelet plug, which is what we call this, isn't strong enough to last for very long. You know, it can last for a few minutes, maybe even an hour, but without something stronger, which is in our case a blood clot, then the platelet plug starts to fall apart, and then the vessel starts to bleed again. You know, in patients with certain bleeding disorders, that's exactly the pattern you see. So like if you prick their finger, they bleed a little at first, which is normal, and then the blood stops, but then 10 minutes later it starts bleeding again. That's because the blood clot never formed. So the platelet plug has disappeared and now blood is coming out again. Okay? So platelets are anything but passive little creatures. They not only become sticky when they stick to something, but they also release a whole bunch of chemicals that then in turn fuel the coagulation cascade, which results in a blood clot. All right, so first phase, vascular phase, second phase, platelet phase, and it ends when there's a plug and we've got all these chemical factors. I'm not interested in you knowing the names of all these chemical factors, just that platelets, when they're activated by getting sticky, they release stuff that then triggers the next phase in the hemostasis system. All right, so phase 1, phase 2. And then the most complicated bit is, we call it coagulation. This is the precise word for the formation of a blood clot. So this is not a blood clot. This is a platelet plug, right? So different things. Now, the blood has stopped flowing here, but it's too weak. So in the coagulation system, the endpoint there is to form an honest-to-goodness blood clot. All right, what's a blood clot? A blood clot is essentially a network of protein fibers that have red cells stuck in them. You can think of it as a kind of net. You know, if you took a fine mesh net and you swished it through water that had a bunch of stuff floating in it, what you'd end up with is a net full of stuff. Essentially, that's what a blood clot is. It's a net that's filled with red blood cells, and it gets very hard, as we'll talk about in a minute. So ultimately, this is what we're getting in the end. I'm going to turn the lights off so you can see that picture better. So down in the lower left-hand corner there is what a blood clot looks like. So those little purple threads, that's a fibrous protein called fibrin, which we're going to talk about where it comes from in a minute. And then you can see how the red blood cells are sort of trapped in that network or that net. Well, eventually, that whole system of blood cells and proteins, it contracts and it gets very hard and very tough. Like we've all experienced, we get some cut on our skin, and the blood clot is actually really tough and hard. And it's because that is how it's made. Okay. But before we can get there, we have to venture through quite a bit of complex biochemistry, which I'm the first to say I'm not a chemist, nor am I a biochemist. So I cover it conceptually as opposed to analytically. So I leave some of these things out. But ultimately, you've got two paths that lead to the same common pathway, okay? So we have the extrinsic pathway, which comes from outside of the vessels. So, extrinsic is outside, intrinsic is inside. Well, inside or outside of what? The vessel. So the extrinsic pathway is triggered by damage not to the blood vessel, but to the surrounding tissues of that blood vessel. If you think about it, you can't cut a blood vessel without cutting something else, right? Unless you're in microsurgery, or something like that. But, if you get a skin cut, it isn't just your vessel that's been cut, it's the surrounding cells have been cut too. So when cells are damaged like that, they release chemicals that trigger this extrinsic pathway of coagulation, okay? Now, inside the vessel, the endothelial cells and the platelets, they too send out signals, send out chemicals that trigger coagulation. So that's the intrinsic pathway, comes from the endothelial cells and the platelets. The extrinsic pathway comes from the surrounding damaged tissues. Now, here's where it gets complicated, and this is the stuff you're going to learn later on when you take your hematology courses, which many of you will take. And that is this process of going from tissue damage to clotting, or activated platelets and endothelial cells to clotting, involves like 15 different biochemical factors, okay? And each of them has a name. The most important ones are named factor 1 through factor 10, and they get Roman numerals because, of course, that makes them look fancy and important, right? So if you've ever heard of the disease hemophilia, hemophilia is a problem with one or more of these factors. Because in order to have coagulation occur, you've got to have each of them. So you've got to have 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. And they all have to work perfectly, or this whole coagulation cascade doesn't work right. So it's a weak spot in our evolution. There's this multi-step process. If you're missing any one of those factors, you don't clot. And that's what hemophilia is. They're missing one or more of these factors. And when they have an injury, those factors have to be given intravenously in order for them to make a clot in the first place. Okay. But like I said, we're not going to get into all that detail here. I do want you to note this, though. See how calcium is on both sides of this? Really simple rule. No calcium, no blood clot. Okay? So here's another spot where my favorite ion, calcium, is playing a pivotal role in something really important that the body does. And that is, without calcium, the factor system doesn't result in coagulation, like we're going to talk about. We take advantage of this when we draw blood from patients. If you've ever looked at the tubes they put your blood into, a lot of times there's a little pellet in the bottom, right? It's not an empty tube, but it's got something in it already. Well, one of the little pellets is a calcium absorber. So when you put blood into a vial that has this calcium absorber at the bottom, all the calcium gets whisked out of the blood, and the blood doesn't clot. It stays unclotted forever at that point because there's no calcium, and if there's no calcium, there's no blood clot. So it's one of the ways that they keep blood fluid is to use that tube. Now, obviously, if you want to check the calcium level of a patient, well, you can't use that tube. Then you've got to use some other tube that doesn't suck up the calcium like that does. Okay, so extrinsic pathway, intrinsic pathway. Now, this big blue arrow is fair game because this is the common pathway, and this is the pathway that we can affect the most with our medications and with our some of our newer treatments. So I do want you to learn this path. Okay, and it starts with factor X, which is factor 10. And I've written it over here. I probably could have just showed you that, but I wanted to show you a little notation. Okay, so here's the intrinsic pathway right on the right. Yeah, that's right, I said left before. But, and extrinsic pathway is the one on the left, as you look at that. Both result in, and I kind of missed a factor here. We'll say factor 10. So both of these result in factor 10 being formed. And factor 10 is an enzyme that triggers the production of this enzyme, prothrombinase. All right, more Lego word time. Okay, pro is pre. In other words, it's a precursor, right? It's a step before. Whenever you see A's at the end of an enzyme, and A's is something that breaks another thing or activates another thing. Because a lot of our proteins in our body are made with a safety switch attached. So until the safety switch is cut off, the protein doesn't do anything. So an A's usually cuts off the safety switch and activates an enzyme. All right? So in this case, prothrombinase activates prothrombin. So prothrombin becomes thrombin because prothrombinase cleaves off the safety switch from prothrombin and turns it into thrombin. Okay? Now, thrombin, when you see that word, a thrombus is a clot. Fancy name for a blood clot is a thrombus. Okay, so factor 10 triggers prothrombinase. Prothrombinase turns prothrombin into thrombin. And then thrombin then takes fibrinogen and turns it into fibrin. Fibrin is this network-like protein that you see in purple here. So fibrin is named because it turns into fibers. Those fibers are sticky, so they make a net, like sticky spaghetti. They don't line up, they're all matted together. And then the red blood cells get trapped in that fibrin and make a clot, right? So that's this blue pathway down the center. It ends with the production of fibrin, and then fibrin results in a blood clot. Now, factor 10, fibrinogen, and factors 1 through 9 are all made by the liver. So I'm going to make a key here. Liver. So if your liver is not functioning properly, you don't make factor 10, you don't make fibrinogen, so you don't make blood clots. It's one of the problems in end-stage liver failure is that these clotting proteins are not produced in high enough quantities, and people don't clot. So they'll bleed and bleed and bleed and bleed. And in addition to the liver making these, in order to have the liver make them properly, you have to have vitamin K. Okay, so vitamin K is necessary for the liver to make these clotting factors, to make this whole system function. No vitamin K, no clotting factors, no blood clots. So you're at risk for massive hemorrhage. In this country, all babies get a shot of vitamin K before they go home from the hospital, sometimes much to the mother and father's chagrin. But the reason for that is vitamin K is made, we don't get much of it in our diet, okay? The only place you find vitamin K is in really dark green vegetables, like spinach is a great example, that dark reddish green. Most of the vitamin K we get is produced by the bacteria that live in our large intestine. So we feed them stuff we can't digest. They produce, among other things, vitamin K. Vitamin K then allows the liver to produce these clotting enzymes. So So why do we have to give it to babies? When babies are born, their large intestines are sterile, right? Because the uterus is sterile. They haven't eaten anything, so no bacteria is in them. It never has been. And it takes up to 3 months to establish a healthy bacterial colony in the large intestine. And in that 3 months, mom's vitamin K, which is what baby has been dependent upon, will have started to, the levels will have started to fall. So before we started giving vitamin K, I point here because that's where we give it, is it was called hemorrhagic disease of the newborn, where babies 3 to 6 weeks out would start having uncontrollable bleeding because of a vitamin K deficiency. So vitamin K is cheap and easy to make, so now we just sometimes very stealthily inject a little vitamin K to every baby before they go home, right? So if you have a baby or if you have had a baby, one of the reasons they'll have a little Band-Aid on their thigh is because of the vitamin K that was given. So it's just standard protocol. Okay, so what happens next in a clot? This bit right here. Fibrin is also not passive. So once fibrin forms a blood clot, the next thing it does is the fibers contract, almost like a muscle fiber contracts. It gets smaller and smaller and tighter. It pulls those red cells closer and closer together until it forms almost like reinforced concrete, where you've got a lot of rocks tied together by this real tight meshwork of cement, right? So it makes for a very strong, tough clot, as we've all experienced on our skin. Another benefit of clot retraction is that it also, say you've got a cut, right, a good sized one, so it's a gaping wound, and then you get a clot in there. As the clot contracts, it pulls the edges of the skin together. So like in a bad cut or you'll see the skin will pucker a little bit around that incision. That is from the clot retraction. So the clot pulls the skin together, and that makes less scar tissue that has to be made then. So by making the gap as small as possible, the healing improves. It's faster, and you have less skin that has to be replaced in the end. Okay. So the last bit I'm going to talk about is clots are hugely important, absolutely necessary when you need one. When you don't need a clot, though, clots are bad, which is what you hear about in medicine a lot. Clots that clog a brain artery or clots that clog a coronary artery. Well, those are clots that you don't need. So there has to be a system for dissolving clots and for preventing them in the first place when they don't belong. One of those systems is the plasmin system. So plasminogen, also made by the liver, also circulating in the blood all the time, is activated into its activated form. Ogen is just like pro. It means a precursor. And if you hear ogen at the end of an enzyme, it doesn't do anything. It's going to do something once it's cleaved, once it's clipped. So plasminogen becomes plasmin. Plasmin dissolves fibrin. So it takes this fibers in this blood clot and it turns them back into plasma. Okay, so it dissolves them, and as the fibers dissolve, the blood clot breaks up. One of the enzymes that makes plasminogen into plasmin is something you'll hear about in healthcare, and that's called TPA, short for tissue plasminogen activator. This is a medicine we can give IV that busts clots, breaks up clots. So many of you will have heard about clot busting. Somebody is having a massive stroke or a massive heart attack or myocardial infarction, and they'll give a clot buster to dissolve that clot and restore blood flow. So one of the clot busters we give is TPA. There's a whole list of them that we give now, but this is the one you hear about most often. And all it does is turn plasminogen into plasmin, and then plasmin dissolves the clot eventually. Because in the end, once healing has occurred, you want to get rid of that clot so that you have a nice normal skin again. And plasmin also plays a role there too. So this is certainly a star-worthy slide because there's a lot of information here, and I know some of it is quite obtuse, right? So this is one I would recommend that you look at in your book a couple of different times, but You can ignore a bunch of these, right? Do want you to know calcium is necessary, though. Know this one, like the back of your hand, and then know a little bit about how plasminogen becomes plasmin, and then plasmin dissolves that blood clot. All right, questions about any of that stuff? Anybody heard this stuff before? A couple of you are gentle nods anyway. All right. Because, this is the blood chapter, and coagulation is one of the fancier things that blood does. So why all this complexity? Why did it evolve like this? Well, probably because you want a blood clot when you need one, but you don't want a clot when you don't need one. So by having all these steps necessary to get to fibrin, it provides a lot of safety. If any one of these steps fails, fibrin isn't made. So biologically, evolutionarily, we have more of a tendency to not clot than we do to clot. Because the clot busting system is simple. The clot making system is complicated. And that could be in part, we've got blood to spare. We can lose 500 mils or even a liter of blood and really be fine, not need to have a transfusion or anything like that. So it's probably better for us to not clot as well as to clot more, as the system would say. Okay. All right. So before we move on to talk about the vessels, we'll talk about a few blood disorders. So here is what sickle cells look like. You've all heard about sickle cell disease, right? It's a classic genetic illness. It's a single amino acid mutation. So one amino acid is different than it should be, and you get this profound effect in hemoglobin. So it's a single mutation deficiency in hemoglobin. These are normal red blood cells, right? But when sickle hemoglobin is present, it has this characteristic that in areas of low oxygen concentration, like you find at the tips of the fingers and the toes and the tops of the ears and the nose where oxygen is really low, the cells, the hemoglobin gets all stuck together. So normally hemoglobin molecules are separate. In sickle cell disease, they all stick together and they make these long chains, so we get cells that look like this. So they're long, skinny cells. And you can imagine traveling through the twists and turns of the blood vessels. This is not going to be a shape that's going to work out very well, right? It's going to get stuck. It's going to get stuck to itself. It's going to get stuck to other things. And that's really the central pathophysiology of sickle cell disease, is that these sickled cells get stuck in vessels and cause infarction, which is a reduction in oxygen and nutrients to cells that makes them die. So the common characteristics in a sickle cell patient is they'll have periods of pain crises. We call them sickle cell crises, where an arm or a leg or a foot or a nose or an ear or a throat will have intense pain from lack of blood flow because of these sickle cells getting stuck and blocking those vessels. Yes?
Have you ever heard of it happening with your hips? Like your hips?
Yes. Hip bones. Yep.
Okay.
The ischial crests and the greater tuberosity, the femur too, because those are weak spots in blood flow. They're not very well blood supplied. Why does this happen? What triggers it? Anything that reduces oxygen concentrations in the body will have a tendency to cause cells sickle. So let's say you got a perfectly normal 6-year-old with sickle cell disease, and they get a pneumonia. Well, when you have a pneumonia, your oxygen concentration goes down a bit. That causes the cells to sickle, and now he was sick already, but now he's got these sickle cell crises popping up too. And sickle cell disease we could talk for 2 days about it, but it's a fascinating illness. We've made great strides in treating and preventing the worst aspects of sickle cell disease, but it is still a leading genetic disorder in America. It's one of the genetic disorders that costs healthcare the most. It costs patients many sick days, many hospital days. A lot of sickle cell patients will end up with opium or opiate addictions because that's the only thing that will treat their pain. So they end up in addiction cycles that can really be a mess. Yes. There are, in some people, certain medications help. the cells not to sickle. Blood transfusion is common as a treatment because these sickle cells, they don't ever go back to this shape, they die. So they're anemic all the time. So we give patients blood transfusions, but there's a limit to how many blood transfusions you can give a person because every time you give blood, you're giving iron as well, and the body doesn't get rid of iron very well. So one of the causes of death is iron toxicity, believe it or not.
So can it lead to amputation?
Yes, because infarction results in necrosis where the cells die, and then those cells can't recover, so they have to be amputated. Yeah. Yeah. Yes.
I've heard of hemoglobin F as a treatment for sickle cell.
Mm-hmm.
What is the function?
It's you trigger hemoglobin. We have two kinds of hemoglobin in our lives. Hemoglobin regular is what we have as adults. Hemoglobin F is what we have as fetuses. Fetal hemoglobin. And what they try to do with hemoglobin F treatment is use it as a backup. So if your normal hemoglobin doesn't work right, if you can trigger hemoglobin F to be produced instead, then it will work not as well as adult hemoglobin, but better than a broken one. Yeah, yeah. And we'll talk, hopefully we'll have time to talk a little bit about hemoglobin F in the respiratory chapter, about why we have two different kinds of hemoglobin. All right, so that's very common with sickle cell disease. This is an example of when your platelets go bad. So our blood vessels, particularly the tiny ones like capillaries, are under pressure all the time, right? The heart is pushing blood through the system, so there's a pressure inside these little vessels. Well, that means that all the time our blood vessels are tearing a little, but because we have working platelets, those little tears are very rapidly repaired. Well, in the case of a massive infection or a massive cancer where your platelets are just not being produced, when your platelet count goes down, you get a rash like you see in the middle. And what that is literally blood underneath the skin that has oozed out of vessels for whom platelets were not there to plug the hole, right? That's just one of, you can see that symptom in a lot of different disorders, but one of the classic ones is in meninge. So meningococcal meningitis is a very rampant infection. All of you have now been vaccinated for it, I would imagine. But it used to be a leading killer of children between 12 and 20. That's why you all get the vaccine now. It's a great thing. But that is one of the things it can look like, is you get this bloody rash. And if you pushed on that skin, that redness would not go away because it's actually blood under the skin. You know how like when you have a swollen ankle, when you push on it, it blanches, it turns white again. You push on that, it doesn't change because it's one of the diagnostic markers there. All right. Oh, and then this one over here. Yes, question.
What's in the meningitis vaccine?
What is in it?
Yeah.
It's not a live virus. It's just antigens.
Oh.
So it's virus that's been smashed up, and then you put the pieces in the patient. Yeah. Okay, so then that one over on the corner. You've all heard of leukemia, right? Well, now you've seen it. That is one example of leukemia. So you take blood out of a patient, and you spin it down, right? So you pack the cells in the bottom. You take the cells, you smear them on a slide. Normally what you see is you see a bazillion red cells, and you have to go hunting for white cells, right? Well, in this case, do you see all that blue? Those are all white cells. And so obviously there's about 1,000 times more than there should be. And you see how no two of those cells really look the same? That's the sign that they're not healthy cells. So what one version of leukemia is the bone marrow gets mutated, some region of the bone marrow does, and starts producing white blood cells in huge quantities. And you'd think, well, wouldn't that be, oh, they're going to diagnose our thing right now. Wouldn't that be great for the immune system? No, because these white cells are dysfunctional. They just like all tumors, they don't do anything right. They just exist. So you get more and more of these white cells, which means fewer red cells. So you get into oxygen problems. the white cells are dysfunctional, so you have infection problems. One of the diagnoses for leukemia is multiple infections that are difficult to treat, right? And the white cells also, or the tumor, it has the bone marrow working in overdrive, right? So the bone marrow does that for long enough and it starts to burn out. It starts to get nutrient deficient. So you can go from that case to having very few white blood cells in a hurry because the bone marrow can sort of blow itself out like that. So there's lots of different kinds of leukemia. This is an example of a myelogenous because these cells look a little bit like neutrophils do. So it's there's different cell classifications, but that's a classic leukemia under the microscope. It's one of the few cancers you can diagnose with a simple test. You take blood out of the patient, smear it on a slide, and you look. And if you see a bazillion white cells, call the oncologist because it's a leukemia. Yes?
So if you just take out that part of the bone marrow that's making all those red blood cells or white blood cells, would it fix it, or does
They
it
can't
spread?
find it.
Oh, it's hard.
Yeah. I mean, it's probably because, hardly ever do you see a cancer occur in multiple places at once. But it's finding out where that is. And maybe someday that's what they'll do is they'll figure out where the bad spot is and they'll go in and cut it out. But today, leukemia, there really is no surgery. It's chemotherapy is the number one treatment. Yeah. Yes?
What causes it? Is it like genetic? Or?
It's mutants. Our cells mutate all the time. And normally the immune system identifies the mutant cells and kills them. But sometimes a cell will escape that surveillance and then it starts to form a tumor. And then as it forms a tumor, it gets even more mutated because it was broken to start with. And they just get out of control. The body has no control over them. So they grow and grow and grow. Yeah.
So when they do bone marrow transplants for people with leukemia, are they hoping that they get the part removed that?
No, the way a bone marrow transplant works is the patient is given so much chemotherapy that their bone marrow is destroyed, demolished, not to exist anymore. So they destroy the patient's bone marrow, and by doing so, they destroy the tumor. But now the patient has no immune system, and they have no way to produce any red cells. So you can't survive like that. So they take the bone marrow stem cells from another patient, put them in the first patient, and then the donor's bone marrow grows back in the patient. Does that kind of make sense?
Then why do the transplants sometimes not work or not?
Because it's hard to kill all of the bone marrow. And tumor cells have a tendency to be more resistant to chemicals because they don't work right anyway. So yeah, usually a bone marrow transplant failure means that the tumor wasn't killed in the first place. So it comes back. Bone marrow cancers are some of the nastiest to treat because, you can't get at it. You want to destroy those cells, but you can't get to them. Yeah. Other questions? All right. Well, we're about out of time, so this is a good place to end it, Sammy. So we'll skip these. All right, so next time we're going to talk a little bit about the